Um, Good evening, good morning, everyone, depending on where you're joining us from. My name is Njokin Jiraini, and I co-chair the CO Pros Working Group. And together with the team from SN, we've been running webinars in terms of pediatric radiotherapy. And today we have one of our esteemed speakers who's going to talk to us about radiotherapy for rhabdomyosarcoma, and one of the things that is very topical, especially for people looking after pediatrics. Arnold Paulino needs no introduction, but for those who might not know him, he's currently sits on the EXCO for PROS. He's actually Director of Pediatric Radiation Oncology and Professor in Radiation Oncology at the MD Anderson. He is very well published, and I think we would not be referencing anything in pediatric rhabdomyosarcoma or pediatric Wilms without talking about Arnold. And today he's going to walk us through radiotherapy for rhabdomyosarcoma. Kindly use the Q&A bot so that we can actually look at your questions after, and we'll be able to get through them, and encourage your colleagues to already join. I think currently we have about 140 people, and I'm sure that will increase. So in the interest of time, I'll invite Arnold to sort of walk us through the presentation. Thank you, Arnold.
Okay, thank you. Thank you so much. So my topic is radiotherapy for rhabdomyosarcoma. So the first thing I would like to say, I work in Texas, so we actually follow the Children's Oncology Group of treating rhabdomyosarcoma, which might be somewhat different from how FACR does. So these are some of the objectives. At the end of this presentation, the participant should be able to discuss the indications for radiotherapy in rhabdomyosarcoma. We are going to discuss the appropriate doses and volumes that we use for the treatment of this disease, and also discuss some of the technological advances that we have for rhabdomyosarcoma. So you can see this slide, and this slide shows you that the outcome for rhabdomyosarcoma has improved markedly, from the 1950s to the 2000s. So if you look at this black line over here, this is the survival of patients with rhabdomyosarcoma. So rhabdomyosarcoma is one of the more common tumors we see here in MD Anderson in the pediatric radiation oncology section. It is the most common soft tissue sarcoma in children, and it counts for about 3 to 5% of malignant disease in children less than 15 years. Its management is quite challenging, and it's challenging because each patient is somewhat different from the other. It's a very heterogeneous group because there are different histologies, locations, and presentations. So here you can see the age of presentation of these children, and you will find that about 60% of them occur in children less than 9 years old, but about 13% are occurring in those 15 years or older. The other thing to note is the primary site. The primary site can be anywhere in the body. So it can be from the top of the head to the bottom of the feet. In general, about 40% of the rhabdomyosarcomas occur in the head and neck region, 20% in the extremity, 20% in the genitourinary tract, and 20% other. And then when we talk about tumor location, there are some locations that have a better prognosis compared to other locations. So the ones that have a better prognosis or the favorable sites are the orbit, the non-bladder, non-prostate genitourinary sites, the non-parameningeal head and neck sites. And you can see their outcome on top, versus the outcome of patients, on the bottom who have bladder and prostate, parameningeal, retroperitoneal trunk, and extremity, and they have worse outcomes. So this is an example of parameningeal rhabdomyosarcoma. You can see here, the tumor, and there's some lymph node metastases here on the right. So these tumors are bad because they have a tendency to involve or erode into the skull base and also have intracranial extension. So there are a number of sites that belong to this parameningeal category, which include the middle ear, nasal cavity, paranasal sinuses, nasopharynx, the infra and pterygopalatine fossa, parapharyngeal area, and mastoid. This is another example of an unfavorable site, which is the extremity. And you can see the tumor here. So this happens to be in someone's lower extremity. One of the things that can happen with extremity tumors is you can have in-transit lymphatic spread, and it happens actually in about 15% of patients with lower extremity rhabdo, compared to about 5% of upper extremity rhabdomyosarcoma. The classic pathologic description is, embryonal, versus alveolar. Embryonal being more favorable than the alveolar histology. And then you have sarcoma botryoides and spindle cell, which are subtypes of embryonal. So it turns out alveolar, about 80% of the alveolar rhabdomyosarcomas have a translocation, either a 213 or 113. So there is a FOXO1 fusion. This particular figure shows you the outcome of patients, of alveolar rhabdomyosarcoma, which are fusion positive, the ones with letter P, and fusion negative, which is the one with letter N. So the blue is fusion negative alveolar. Fusion positive alveolar is the yellow. So you can see that the fusion positive alveolar actually does the worst. The fusion negative alveolar and the embryonal have about the same outcome. And if you look at, alveolar fusion positive, alveolar fusion negative, there are more patients that are metastatic when they're fusion positive. So actually in COG, we started using the terminology fusion negative or fusion positive, rather than saying, alveolar embryonal. So the other thing that makes it complicated is we have a grouping system in rhabdomyosarcoma. And this grouping system is actually beneficial for us radiation oncologists because it determines which of these patients we need to radiate. So group 1 patients are those that are completely removed with negative margins. Group 2 is if you have a gross total resection, but you have a positive margin, okay, or if you have regional lymph node spread that has been resected. And then group 3 is if you have gross residual disease. So this is after a biopsy only, or if you have a subtotal resection. And then group 4 is distant metastatic. So, based on where these tumors are located, based on their tumor invasiveness, size, and lymph node status, and also metastatic spread, we can determine the stage of the patients. So the favorable sites, which are the orbit, other head and neck that's not parameningeal, non-bladder, non-prostate GU, biliary tract, they can only be a stage 1 or a stage 4. So these sites are a stage 4 if they have distant metastatic spread. So the unfavorable sites cannot be a stage 1. Okay, the lowest that they can be is a stage 2. as you can see here. If you have a tumor that's greater than 5 centimeters, then they become a stage 3. Or if you have regional node metastases, then they become stage 3. And then again, if they have distant metastases, they become a stage 4. So if we know the stage of these patients and also the fusion status and the group of the patients, we can have this risk stratification. We can classify them as either low risk, intermediate risk, or high risk. So low risk patients are fusion negative only. So you cannot be low risk if you're fusion positive. But these are patients with group 1 or group 2 disease that's either stage 1 or stage 2. Okay, an exception is a group 3 tumor that's a stage 1 located in the orbit. Those patients, those group 3 patients have a very favorable outcome. The high risk category is any fusion positive that's group 4. Okay, but you can also have fusion negative that's group 4 if they're older than 10 years old. Those are considered high risk patients. So the rest of the patients, which is most of the patients, will be the intermediate risk category. Okay, so in COG, about 60% of the patients are intermediate risk, 28% are low risk, and 12% are high risk. And this is the 5-year event-free survival, depending on the risk category. So if you're low risk, you're 90%. Intermediate risk, 56 to 78%, depending on whether you're fusion positive or fusion negative. And then if you're high risk, it's 11% to 41%, depending again if you're fusion negative or fusion positive. So fusion positive, that's high risk, only has a 5-year event-free survival of 11%. So this is the treatment algorithm for rhabdomyosarcoma. For low risk, intermediate risk, and high risk, we start typically with chemotherapy, and usually the backbone is chemotherapy is VAC, which is vincristine, actinomycin, and cyclophosphamide. And local control is typically delivered after week 12 of the chemotherapy. Okay, so there are 2 methods of local control. You can do surgery or you can do radiation therapy. So here in North America, about 35% of cases at initial diagnosis are resectable. 15% will be group 1, and 20% of S will be group 2. We don't usually do surgery for sites such as the orbit or parameningeal, where a gross total resection will be mutilating, and also you can lose function. So why do we use? Why is it that radiotherapy is often used for rhabdomyosarcoma? Well, the reason is because rhabdomyosarcoma, unlike the other soft tissue sarcomas, is radiosensitive. So it can actually be used for hard to resect sites and also for metastatic sites. So this is the radiotherapy doses that have been used in the intergroup rhabdomyosarcoma study 4, in intergroup rhabdomyosarcoma study 5. So someone who's embryonal, so that will be equivalent to a fusion negative, that's a group 1, will not receive radiation therapy. Okay, but an alveolar would get radiation in the IRS 536 gray. If you are stage 2 with positive margins, you got 36 gray. If you had positive lymph nodes that have been removed, you got 41.4 gray. The orbit in IRS 4 got either 50.4 or 59.4 when they're a group 3. And then in IRS 5, they got 45 gray, was lowered. Non-orbit, 50.4 or 59.4. and then in IRS 5, 50.4, and group 4, 50.4. So why did we go back to 50.4 instead of 59.4? Because there was a randomization between 50.4 and 59.4 gray, for these group 3 tumors. Now, one thing I want to mention is the higher dose, which is the 59.4 gray. They were not treated with 1.8 gray fractions, like the conventional radiation therapy for 50.4 gray. They were given 1.1 gray BID. So what this found was the incidence of local failure was the same. It was 13%, whether you use the higher dose or the standard dose. Okay, but it seems that for certain sites, you had more acute toxicity when you give the higher dose of radiation. So after the study was done, the standard of care continued to be using 50.4 gray radiation, for group 3 rhabdomyosarcoma. But for orbital rhabdomyosarcoma, because they have a good outcome, we have tried to lower the dose of radiation to 45 gray, which you can see here in the D9602 study, where they use 2 drugs, incretin actinomycin, and the local failure rate is 14%. And this is quite similar, to IRS 3 when VA chemotherapy was given, so only 2 drugs were given. Local failure was 16%. And then you can see here when 3 drugs are given, such as in the IRS 4, the local failure rate was only 4%. So the thinking is maybe we should be using 3 drugs for these patients. And so in the next COG study, in the ARST0331 study, VAC was given, but you can see that the local failure rate was still 13%. So it turns out that when we gave 45, when the patient had a complete response, and we gave 45 gray, that in this study there were no local failures. Okay, but if they had a partial response or stable disease and they were given 45 gray, there was a 16% local failure rate. So after this, analysis was done, the recommendation was we can try to lower the dose to 45 gray if the orbital tumors have a complete response after the induction chemotherapy. But if they didn't, we should stick to 50.4 gray. Okay, so who needs radiation therapy? So in the COG, anyone group 1 that's fusion positive, group 2 patients, group 3 patients, and group 4 patients. So essentially about 85% of the patients will need radiation therapy. So one of the things that we have found in the COG is that the bigger tumors, those that are greater than 5 centimeters, they have a worse local control compared to less than 5 centimeters. So less than 5 centimeters, you can see your local failure rate is only 10%, but if you're greater than 5 centimeters, it's about 25%. So because of the higher local failure rate in the bigger tumors, what the COG did was to dose escalate those patients who don't have a complete response at week 9 if they have tumors greater than 5 centimeters at initial presentation. So here are the doses that were used on the last intermediate risk protocol. So the group 1 fusion positive got 36 gray, group 2 patients got 36 gray. If you have a less than 5 centimeter tumor, you got 50.4 gray if you're group 3. But And that's assuming you didn't get a complete response. If you were a bigger tumor, you were dose escalated to 59.4. You can see here that if you get a complete response at week 9, you can lower the dose to 36 gray. And then there is a possibility that you can have what's called a delayed primary excision. And if you do a delayed primary excision, you're able to lower the dose of radiation. So if you get negative margins with a delayed primary excision, you can give 36 gray instead of 50.4 gray or 59.4 gray. And if you have a positive margin, you can give 41.4 gray. So this was recently presented in ASCO last year. This is the result, of dose escalation. So you can see the fusion status didn't matter as far as the local failure rate. The tumor size did matter. Those that were 5 centimeters or greater had a 25% 3-year local failure rate compared to 10% with less than 5 centimeters. And whether they use protons or photons, there was no difference in the local failure rate. For the 81 patients with greater than 5 centimeter tumor and gross residual disease after induction chemotherapy, about 3/4 of them received the protocol specified dose of 59.4 gray. So those patients who got this 59.4 gray, the local failure rate was 32%. But those who did not at 59.4 gray, so the total dose was 50.4 gray, the local failure rate was 16%, which was not statistically significant. So in this particular study, the dose escalation didn't help reduce the local failure rate. One of the interesting things in this particular presentation was that the non-parameningeal rhabdomyosarcomas who had the delayed primary excision had a 3-year local failure rate of only 6% compared to those who didn't have a delayed primary excision of 22%. So this was reported only in abstract form, so it hasn't been published as a manuscript. So the next thing we should talk about is metastatic rhabdomyosarcoma. And there are many prognostic factors for patients with metastatic rhabdomyosarcoma. And one is where they metastasize. If they're lung only, usually they do better. Okay, and then the other thing is that they have one site, they do better than 2 or more sites. So this is a publication here from Houston, where all the metastatic sites, we tried to treat all of them with radiotherapy. Primarily, there were a few that got some surgery for metastatic sites, but primarily they were treated with radiotherapy. When we treated all the distant metastatic sites, you can see that survival was around 30%. And then those that we didn't treat, all the metastatic sites, none of them actually survived. This is a study from COG where they look at 4 different North American IRS or COG studies. They look at whether these patients with metastatic disease had whole lung radiation and no whole lung radiation. And you can see here an improvement in the event-free survival when whole lung irradiation was given. This is a study from Europe, EPSSG MTS 2008. And this is when they gave radical or partial radiation to metastatic sites versus no radiation. And you can see here an improvement in the progression-free survival. But if you look at radical radiation versus partial radiation, radical radiation meaning treating all the metastatic sites, there was actually an overall survival benefit with treating all the metastatic sites. And again, you see here radical radiation, does better. Age of the child, children 1 to 9 years old do better compared to less than 1 and greater than 10. Favorable sites do better than unfavorable sites. And if you have 1 to 2 metastatic sites, you do better compared to 3 or more metastatic sites. So the current thinking is we should try and attempt to treat all the metastatic sites if we are able to. And in fact, in COG, there is now also an option of doing stereotactic body radiation therapy. And you can do doses of 30 to 35 gray in 5 fractions, for bone lesions that are less than 5 centimeters. What about omission of radiation therapy? Sometimes we omit radiation when we have a complete response to induction chemotherapy. I mean, that's not typically the recommendation, but some people have done this, and sometimes when we have very young children, we don't particularly want to use radiation. So this is an international workshop for orbital rhabdomyosarcoma, and you can see here the intergroup rhabdomyosarcoma study and 3 European groups. And you can see that patients who had radiotherapy had better local control compared to patients who didn't have radiation therapy. But despite that, the overall survivals are pretty much the same because we can salvage this orbital rhabdo patients. But for parameningeal rhabdomyosarcoma, the omission of radiation therapy actually led to a worse event-free survival and overall survival. This particular slide shows you the COG experience with infants. There are 124 patients that were reported in this study who were less than 2 years old. The median age was 14 months. And the most common site that was treated was genitourinary, followed by parameningeal, which was 14%. So 58% of patients receive radiation. So you can see right away, that only 58% got radiation. And I was telling you that around 85% of patients, usually with rhabdo, will get radiation. And the median dose delivered was 48.6. And local failure was most frequent in patients with individualized therapy, compared to protocol-specified therapy. So they got protocol-specified therapy, the local failure rate was 16%, and individualized therapy, it was 35%. So in the COG guidelines, for infants, they're very strict about the fusion-positive patients, and they really want these patients to be treated per protocol. But for the fusion-negative patients, there's some leeway, as far as the radiation therapy. It's up to the discretion of the treating clinician. So what clinical target volume did we use? Well, I was trained a long time ago when actually we didn't have the term CTV, PTV, or GTV. So basically we had radiographs and we would draw the tumor in like the DRRs, what we call like a DRR now, and added 2 centimeters to that and put a block at 2 centimeters. And basically that's the block edge. That's what we treated. When we started using volume-based radiation therapy, we defined the CTV1, which is the initial tumor before any treatment has been given. And then the CTV2 is the tumor after induction chemotherapy, which is usually after week 12. And you can have 2 volumes. You have a bigger volume, for the CTV1, and you give that 36 gray. And then for the cone down, you give another 14.4 gray. such that the primary tumor receives a total dose of 50.4 gray. In the COG studies, we continued to use this 36 gray and 14.4 gray for cone down, but the margins were a little bit different. It was 1 centimeter and 1 centimeter for both the initial field and the cone down. So as I mentioned, the cone down boost 2 radiotherapy volumes are treated instead of 1 volume, and usually the cutoff is around 36 gray. Okay, the advantage of this approach is you can lessen the dose to the surrounding normal tissues. So there have been a couple of institutions, prior to this being a very popular approach, there have been some institutions that have used this strategy. This one is from Atlanta, where they treated 14 patients, and they had a good local control using this cone down boost. And then this one is from Philadelphia, where they compared their patients who had, 1 volume treated versus 2 volume treated, and no difference in their local control. So in the COG guidelines, the GTV1 is defined as any visible or palpable disease by physical exam or imaging, CT, MRI, prior to any surgery, chemotherapy, okay? And you can modify this depending on, the location. If you are going into, for example, a cavity, the GTV can exclude the volume which extends into the cavity. The CTV1 is defined as the gross tumor volume, plus 1 centimeter. So it's bounded by anatomic constraints, okay, and it doesn't go outside of the body. And you're giving 1 centimeter to treat areas at risk by microscopic disease. Sometimes, if you have lymph node involvement, sometimes you have to include, the regional nodes, and that would be part of your CTV. When we treat the nodal disease, we usually treat the entire region, okay, and then after the entire region is treated, you can cone down to where the gross nodes are located and give them a higher dose. So in our clinic, for example, we usually give, 41.4 gray to the entire nodal region, and then cone down to the gross nodes so that it gets 50.4 gray. And then the PTV, which has to do with your daily setup and also immobilization, that will depend on your institution. Typically in the head and neck region, we use 0.3 centimeters, and then in the rest of the body, we typically use 0.5 centimeters for our PTV. Okay, as I said, volume reduction is permitted. You can have a cone down if you're giving 41.4 or 59 to 59.4. Actually, now we shouldn't be using 59.4. It should be 50.4. But one of the things that we should be concerned about is we don't want to do volume reduction if the tumor is very invasive. So some of these parameningeal rhabdomyosarcomas, it's very difficult to determine the actual response. And these are tumors that are very invasive. And so you just have to be very careful of doing a cone down in this particular site. I don't do much cone down in the parameningeal rhabdomyosarcomas compared to other sites in the body. Okay, and the GTV2, CTV2, and PTV2 definitions are based on the induction chemotherapy residual, instead of at presentation. So this is an example of an orbital rhabdomyosarcoma. So the GTV is in red, okay, and then the CTV is in blue, in aqua. Okay, so you can see that the CTV is not going inside the eye, and it's not going into the bone, because these are anatomic barriers, and the CTV is not going outside of the skin. This is an example of parameningeal rhabdomyosarcoma where we're including the bone, in the CTV, okay, but we're excluding the brain, in the CTV. So many ways of treating rhabdomyosarcoma. You can do it, 3D, IMRT, proton therapy. When IMRT was first released, a lot of folks started using IMRT, and found good results. In fact, in the COG study, 87 patients, about 85% of them were locally controlled. So this is the same COG study, COG-D 9803, where they compared patients who received 3D radiotherapy versus IMRT, and really no difference in the local control of these patients, 15% versus 18%. Okay, but the main difference is that some of the structures were getting less dose with IMRT, such as the brainstem, and then the PTV, the target, is actually getting more adequate dose when you do IMRT compared to 3D RT. Proton therapy is being increasingly used, especially in Europe and North America. And the advantage is the lack of the exit dose. There was a proton consensus conference in Stockholm, and one of the sites that was discussed was rhabdomyosarcoma. And as you can see here in blue, it's proton versus photon. And so, 18 respondents said that proton would be beneficial. 10 said that photon is good enough. So more people thought that proton would be beneficial for rhabdo. And this was the first paper that was published in JCO, with a lot of patients treated with proton therapy from Mass General and MD Anderson. And you can see here, the local control here is around 85%, higher for the low-risk patients compared to the intermediate risk patients. Year where I work, we look at 94 children treated from 2006 to 2017, treated with proton therapy. Half of the patients had head and neck primaries, and about a third of them had greater than 5 centimeter tumors. So about 2/3 had intermediate risk category, 20% were low risk, and 13% were high risk. And the median proton dose was 50.4 gray. And you can see here the overall survival, which is around 70%. Progression-free survival, slightly lower than that. But the local control was 100% for the low-risk patients and was about 85% for the intermediate risk patients. Now, the high-risk patients, which we didn't have very many patients with high risk, it was worse compared to the low risk and the intermediate risk. But the other thing that we saw is what COG found. Our local failure for less than 5 centimeters or 5 or less is 7%. Okay, and then for greater than 5 centimeters, it was 33%. So this is an example of a patient that was treated, a 16-month-old with a 2.5 centimeter left nasolabial mass. The biopsy was fusion positive rhabdomyosarcoma, and the workup did not reveal any other spread. So this patient was a group 3, stage 2, intermediate risk, started VAC chemotherapy, and at week 12 showed some shrinkage, partial response, and we were deciding whether to do surgery or radiation. As you can see, surgery here can be mutilating. So we decided to do radiation therapy for this patient, and this patient was treated with proton therapy. So these are some examples of studies that have been reported with photons and protons. And this is the biggest study, which is the COG study, where you have about 82 to 85% local control rates. And this is quite similar to what has been reported from, Dr. Timmerman's group of parameningeal rhabdos. These are bad actors. They had an 83.8% local control rate. Here at MD Anderson, 85%. Florida at 2 years, 88%. So the other option, of course, is to do brachytherapy. And this is done in special institutions. And personally, I don't have any experience with this, but there are some around the world who have great experience, like in France and also in India. And this is a study where they included 16 children with nasolabial rhabdomyosarcoma. And they did low-dose brachytherapy. You can see here the local control in blue, which exceeds 70%. And under follow-up, it's not exactly all without toxicity. So even if you give brachytherapy, there's still some possible late complications of radiation therapy. This is a study from the Netherlands where they did brachytherapy for orbital rhabdomyosarcoma, 20 patients. Some of these patients had relapsed. 7 out of the 20 had relapsed, and they were treated with brachytherapy. You can see here that out of these 20 patients, 4 of them relapsed, and then had an exenteration. What's interesting in this study was there was no facial asymmetry or growth anomalies that were reported, but 2 cataracts and 1 mild retinopathy. So in conclusion, rhabdomyosarcoma is treated with chemotherapy in a local control strategy, with the most common strategy being radiotherapy. Currently, we've had 2 studies now here in North America that have dose escalated, the dose for group 3 tumors. One is IRS-4, and the other one is the ARST study 1431. Both showed no difference in the dose escalation. For group 3 orbital rhabdomyosarcoma, we treat them with 50.4 gray unless they have a complete response after induction chemo, and then we reduce the dose to 45 gray. For many of the sites, we use 2 volumes. We treat the initial tumor prior to chemotherapy or surgery as the first volume, and then the second volume will be the post-induction chemotherapy tumor volume. And we're very careful about this, especially in the parameningeal sites, where sometimes we just use just 1 volume. So intensity modulated radiation therapy and proton therapy for rhabdo has resulted in excellent local controls, and so has brachytherapy and 3D radiotherapy. And the omission of radiotherapy in group 3 rhabdomyosarcoma results in a higher local failure rate, and in some sites can impact on survival. Okay, thank you.
Thank you, Dr. Paulino. This is Bilal, and it's been really great talk, very enlightening. Thankful to Beate Timmerman from West Germany Proton Essen, who along with the Pediatric Radiation Oncology Society and the PROS working group of SAB Global Health Network helped organize this talk. We do have some questions, Dr. Paulino, in the Q&A. So if you want, I can read it out. Dr. Beate, shall we move forward to the Q&A?
Yeah, maybe, Arnold, let me thank you again for being willing to contribute to this initiative. I think this was really great, and it's always very enlightening when you're speaking about rhabdomyosarcoma. So thank you very much. Bilal, maybe you allow me to start with the first question before moving to the other Q&As. So,
Sure.
Arnold, I remember that in one of your papers, the intracranial tumor extension had impact on unfavorable prognosis. So, but you didn't mention it, I think, today. So is there any, let's say, updated results that intracranial extension for perimeningeal disease is not anymore so relevant, or do you still consider it a risk factor?
Yeah, the reason why I didn't include it in my talk is because it's controversial.
Okay.
So in our institution, we tend to, if you have intracranial extension, we want to start the radiation, perimeningeal with intracranial extension, we want to start the radiation within 4 weeks, of the diagnosis of starting the chemotherapy. And because in our experience, those patients don't do very well when we treat them at week 12. In the initial intergroup rhabdomyosarcoma studies, they actually gave the radiation upfront. When they had intracranial extension, base of skull, cranial nerve palsy, and then later on they found, you have base of skull erosion, or if you have cranial nerve palsy, you're okay to do it at week 12. And the COG, as far as I know, now I'm not, in the COG soft tissue sarcoma committee, but as far as I know, I've always asked them this question all the time: is how come we're still treating at week 12, but apparently they haven't seen, increased recurrences, when we treat at week 12 or week 13. Yeah, so I am nervous about it. There are other colleagues of mine that are nervous about it also, because once it goes to the brain, it's very hard to cure them if you don't do a good job.
And do you do always a cerebrospinal fluid investigation if you have perimeningeal disease?
Well, that's what's been recommended, like for our residents, taking their boards, that's what we say. But actually, how many we've done this a lot, and I don't even remember anyone who's been positive.
Yeah, that's true. But
So
but
I
we
don't
see CNS
really
dissemination though, so afterwards.
Yeah, I mean, I don't think it's wrong to do it.
But you're not pushing it.
Yeah, I'm not pushing it.
Okay. So then thank you, Bilal. I hand over to you to go through the Q&A.
Thank you, Dr. Beate. So the first question is about the correlation between the location of the tumor and the incidence of translocation. So I believe the person wants to ask that if there are any specific location where you see FOXO1 positivity more. I'm just assuming
Yeah.
this.
That's a good question. So the patients who have extremity lesions, those are the ones that usually will have fusion positive disease, and also perineal, like in the perineum. Those tend to have, fusion positive.
Yeah. So Dr. Paulino, you spoke and you had some slides about younger children with rhabdomyosarcoma for radiation therapy. This question is about the timing of radiation therapy for perimeningeal rhabdos in children who are younger than 3 years of age.
Oh, that's a very difficult question, because, in very young children, as I told you, sometimes we bend the rules. Instead of giving the radiation, like at week 13, we do it more towards at the end of the radiation to make them older. But I think if they have intracranial extension, I think I would do it sooner rather than, it all depends on how old the child is. If it's someone 3 years old, I'd probably do it within the first 4 weeks. But if it's someone, for example, who's like, less than 24 months, then every month kind of counts. So I might go slower. I don't think that there is exactly a right or wrong answer in this. Actually, I'm interested in what Dr. Timmerman thinks.
Dr. Timmerman, anything for the perimeningeal younger than 3 years of age for the timing of start of local treatment?
Yeah, I think we handle it typically very individual. So in the former CWS strategy, radiotherapy at age below 3 years of age was always made on individual decision. There was no clear recommendation. So typically what we did is we, let's say, observe response to chemotherapy. If the response to chemotherapy is good, then we may wait a little bit longer. If the response is poor, then we may start radiotherapy earlier, particularly in sites where we do not have salvage options. So also, like you mentioned, for example, in an orbital rhabdomyosarcoma where we have salvage opportunities, we would maybe even leave it completely out, even acknowledging that the local failure rate would be higher, but knowing that we can salvage. So I think it depends on response to chemotherapy, age, salvage options, and then it's very much an individual decision.
Okay. Thank you. So Dr. Arnold, again, about timing, do you always do radiation at 12 weeks?
So we tend to do it at week 12, week 13. And, after the induction chemotherapy, even the high-risk patients, we tend to do it, at week 12, week 13. Yeah. With the exception of what I mentioned, if we have a patient with perimeningeal with intracranial extension, we recommend we start within 4 weeks.
Okay. So what are your comments on brachytherapy for the urogenital rhabdos?
Well, I think it's good, but I don't do it. So I don't really, that there are some published reports in it. So if you can find a place, and I think in France, there's a center in France who has a big experience in this.
Yeah, there is a group doing it, and they have also published on it. There's also a group in Germany from Jörg Fuchs and colleagues. We are right now doing an analysis of local therapy for GU rhabdomyosarcomas, where we we wanted to compare, let's say, protons, photons, brachy. But of course, we figured out that the selection of tumors is very different for brachy or protons. So typically they have the smaller ones and we have the larger ones, so it will be very difficult. So what we do right now is we have a local therapy tumor board where oncologists or pediatric oncologists, but also surgeons and radiotherapists meet, and also a brachytherapy expert is invited, and we try to discuss all cases where to refer to brachy or proton or whatever. But I think it's very hard if you're not doing it like Arnold or myself, I think it's very difficult to judge on it. So I think this is something where you really need to invite an expert to look at each case and to say if that is a good option. Typically, I would say it's a smaller tumor which should be referred to brachy. And it's typically a combined approach of surgery plus brachy.
So here in MD Anderson, they have excellent adult radiation oncologists who do this brachytherapy for, head and neck and prostate. And I always ask them when I have a child, what do you think? Can you do brachy on this child? And they're afraid because they said the structures are so small and they don't have experience with that.
So Dr. Arnold, the next question is a longer one. This is about a case who is 2 years of age who presented after total excision done at local hospital with large mesentery-based abdominopelvic tumor, and post VAC chemotherapy 6 weeks was given, and the recent scan shows that remnant mass but metastatic looking abdominal lymph nodes are present as well. So to summarize, this is a stage 3, group 3 intermediate risk tumor. Because of the abdominal location, I believe it is difficult to give radiation therapy. So how would you manage the organ at risk doses?
Yeah, I don't think I can answer this question, really well without actually seeing all the data. If it's someone with peritoneal, is it someone with peritoneal metastases? Is that what it sounds like?
No, it doesn't say peritoneal metastasis, but it does say mesenteric nodes.
Yeah, I mean, I don't think depending on where the location of these nodes are, I mean, I don't know if you can safely give radiation. If it's a diffuse involvement of mesenteric nodes, I don't know how you can, I don't know how you can give a meaningful dose. I mean, I've treated the whole abdomen before, but in the setting of peritoneal metastasis, where, those mets, they shrink with chemotherapy. We do the induction chemo first. They shrink with chemotherapy, and then the surgeon removes as much as possible what they can see, at week 12, and then we give radiation after.
Okay, so we do have about 30 more questions in the chat box in the Q&A. Do we proceed with them? We have approached Dr. Arnold.
Yeah, maybe one more question because I have to go to clinic also.
Oh, okay. So let me choose the one. Okay, so I'll choose this one, which is obviously top of the list. So is there any restriction on the number of nodes, a number of metastatic sites that you would offer radical radiation therapy?
Yeah, this is a good question. To me, the most benefit would be, the ones where we really have oligometastasis. So I've radiated up to 4 sites, actually up to 5 sites. I treated one patient with 5 sites. But in general, if they have like 10 sites, it's almost impossible to do that. And then the other thing you have to think about, how long, if you're going to treat, for example, 5 sites in the body, how long are they going to be on treatment? A lot of these patients are also under anesthesia. And it can, it might take like 2.5 hours to deliver the treatment each day. Yeah, so you have to be careful. In general, when you have very many sites, what I look at is the response to the, by the way, when I treat the metastatic site, I tend to treat them at the end of the chemotherapy. So at the end of the chemotherapy, I look at their response to the chemo. If they still didn't respond to chemo, I'm more likely to treat that metastatic site. If it's in a location, where function is very important, then I tend to treat that particular metastatic site. So I look at all these different factors. If there's too many of them. Yeah, but if there's only like 4 of them, I try to treat all 4.
Arnold, may I suggest that, or I don't know if I can dare to ask you, but in the pediatric course, we sometimes collected the questions and tried to answer it afterwards in a written format. Would you be willing to look through the questions maybe, afterwards and send it back to us? Or I can also help you with answering it, because it's in a way, it's
Sure.
not to reply to the questions. So Bilal, can we make sure that the questions are collected and stored, and that Arnold, and if he wants also me, would answer it afterwards to send it back to the audience? Bilal, do you think we are able to save
Yeah,
that?
I think I'm able to copy the questions that Just give me a second. Yeah, I have got all the questions on a Word document right now, so I can email them to both of you.
Yeah, you can also
And
email
I'm,
it to me. I make it a kind of
yeah,
table where Arnold and myself can enter some comment. What do you think, Arnold?
yeah,
Oh, it sounds very reasonable.
yeah, yeah. So I'll work with the PsyOp office to on working on how to make it available to the participants. So all these lectures of these webinar series goes to the PsyOp Global Health Network YouTube page. So maybe we provide a link to a shared document or post the answers there as well. Yeah. So Dr. Beate, would you like to conclude the session?
Yeah, so Arnold, thank you again. I think you gave us very important insights into rhabdomyosarcomas. It's a challenging disease, I think, for every one of us dealing with it. So thank you for your contribution. And of course, also
You're
thank you
very
to
welcome.
thank you to the audience. I hope you had a good hour with us and that you could find good answers from Arnold, and maybe you will have some more seen then in a written format. Thank you.
Thank you.